Dr. Brian Kaufman, family doctor with CLL, doctor turned patient.
My name is David Steensma. I'm a hematologist-oncologist and member of the adult leukemia program at Dana-Farber Cancer Institute in Boston.
So I wanted to ask you, Dr. Steensma, about myelodysplastic syndrome, and if you could kind of define what that is and maybe talk a little about primary, secondary.
The myelodysplastic syndromes are a group of bone marrow failure syndromes. What I mean by that is that the bone marrow does not adequately produce numbers of red cells, white cells, or platelets, which are its primary job. These syndromes can also, over time, turn into acute leukemia. So they've sometimes been called pre-leukemic syndromes, although most patients don't ever get full-blown acute leukemia who have myelodysplastic syndromes or MDS. About 85% of the time, MDS just comes out of the blue. There's no clear reason why the patient got it. But about 15% of the time, the myelodysplasia is treatment-related or secondary to treatment for another disease, such as breast cancer or lymphoma, or even sometimes CLL.
Are there any particular agents that we should be careful about as a patient with CLL or treating a patient with CLL that increase the risk?
The one class of chemotherapy drugs that's most clearly associated with secondary MDS or treatment-related MDS are the alkylating agents. So for CLL, this is chlorambucil, and to a lesser extent, bendamustine.
To a lesser extent, bendamustine? And is that just because we have less experience, or is that?
There may be something actually different about the way bendamustine is used. The fact that it's often given in pulses, whereas chlorambucil was given at low doses as a pill, as an oral agent chronically. There may be something different chemically about bendamustine compared to chlorambucil also. All that we know at this point is that the reported rates of secondary MDS in patients treated with bendamustine seem to be less than what was seen in the chlorambucil era, whether that's an effect of the different drugs themselves or the different ways that the drugs are administered. The other major risk factor for secondary myelodysplastic syndromes is radiation exposure. After the Hiroshima and Nagasaki events, even 50 years later, there was an increased incidence in MDS in the people who were exposed to the atom bomb explosions. It's much less of a risk for people who are getting scans or people who are getting mammograms or just the background radiation in the environment. It's much more a risk for people who are getting high-dose radiation, for instance, as treatment for breast cancer or in a nuclear accident or something.
So let me drill down on both of those issues. The other drug that a lot of us with CLL take is cyclophosphamide, part of the FCR. Is that, that's another alkylating agent? What's the story on that?
It is. So cyclophosphamide certainly can induce secondary MDS. But again, the doses and the relatively short periods of time that patients are receiving cyclophosphamide and FCR means that the risk is a little bit lower. There is, I must say, some concern among the medical community now that patients who are at risk for CLL and develop CLL may intrinsically have something wrong with their bone marrow that predisposes them also to get MDS. We have seen cases of MDS in patients who've received only rituximab or only fludarabine, agents that are not clearly associated with secondary MDS. So, and some of the mutations that are being described in MDS cells are also being described in CLL cells, suggesting that there may be a common predisposition that a stem cell could give rise to both disorders.
So you're anticipating my other questions. The purine analogs then are relatively safe in terms of myelodysplastic or other myeloid cancers?
That seems to be the case. There is an increased incidence. There have been papers that have shown in patients treated with fludarabine that the rate of MDS was higher than expected for the background population, but it's much lower than with chlorambucil or with radiation therapy.
And radiation therapy, you keep emphasizing therapy. A lot of us get a lot of CAT scans,
Right.
and you know, top to bottom, with and without contrast. So should we be worrying about, should we be worrying about that dose of ionizing radiation? I know there's no safe threshold.
Right.
What's the story on, because CAT scans are not just increasing for us, what's the story on that, just the diagnostic radiation?
Well, the relative dose that's that the patient is exposed to from a diagnostic study is much less than for somebody who's getting radiation as a treatment for a disease. That being said, for patients who are living many years and having many scans, there probably is a measurable risk. That has been somewhat difficult to quantify, but we encourage people to get as few CAT scans and PET CTs as they can. Most recurrences, it has to be said, are either detected by the patient themselves, they feel a lymph node, or by the doctor on a routine physical exam. So the majority of recurrences are not picked up by CT scans. There is still value in doing them from time to time. Sometimes you find things that need to be acted on, but the less that one can undergo such scans, the better.
Tell me a little bit if there's anything we can do, a patient can do, a hematologist can advise their patient to do to lower the risk of a secondary hematological malignancy when you already got one.
Yes. Well, at this point, the one thing that we know can help protect is to avoid the agents that are known to be associated with secondary MDS. In this era where there are now various tyrosine kinase inhibitors and antibodies and things that are unlikely to cause secondary MDS, preferentially treating patients with those sorts of agents rather than some of the agents such as chlorambucil that can induce MDS, it should be a priority. Really, I think the only patients in this day and age who should be getting chlorambucil are those who are very elderly, for whom the risk of MDS is small just because their life expectancy is relatively short anyway. I think a younger, healthy patient with CLL should really avoid chlorambucil in particular.
One of the papers here is that exercise, and this isn't dealing with people who already have one hematological malignancy, it's just dealing with the general population, but exercise seemed to have a significant 50% reduction in the risk of myeloid cancer. So that's...
It's not clear why that would be, but exercise is certainly good for all of us. So I think that is something that we can recommend to those who are physically capable of it.
Is the MDS that you get that's a secondary, that 15%, that's a different MDS? Doesn't that tend to be a more aggressive MDS?
It does, Brian. It tends to be really very difficult to manage. And most patients undergo a stem cell transplant if they can, just because their risk is so high if they have a secondary MDS. A very high-profile patient this past year, I think, put a face on that sort of a problem, and that is Robin Roberts, the anchor of Good Morning America. She had been treated several years prior for breast cancer with chemotherapy and localized radiation, and she developed secondary myelodysplastic syndrome. She was fortunate in that she had a donor available, a matched donor, and so she has been able to undergo stem cell transplant, and so far so good. But I think that really helped heighten awareness among the general public of this potential complication. It is still relatively rare compared to many of the other things that happen, but it is something that definitely needs to be on the radar screen of hematologists who are caring for patients with CLL, and the patients themselves should be aware of it.
Any final thoughts or advice that you want to give a patient or your community hematologist about how to approach this? Well,
I think that the treatment for myelodysplastic syndromes is improving. We have several newer agents, and we have stem cell transplant is getting better. The survival after it is improving. Every 5-year block that you compare for the last 30 years, it's a little bit better. And so secondary MDS, while it is a major problem and a big deal, and we'd like to do anything we can to avoid it, it is not the end. There are things that often can be done to help patients with that condition.
And that transplant also is sort of a double whammy in the good sense, because it will also help with the CLL.
It can do. So
Yeah.
there are patients certainly who go into transplant with both diseases and are cured of both.
Thanks so much. Thanks.
My pleasure, Brian.